right, thank you and welcome to the Epidemiology 101 session. I am Charmaine Brothers and will be your moderator this morning. Some Zoom housekeeping rules to make this experience the best possible for all. Please keep muted when not speaking. We welcome you to have your camera on, but it may affect your bandwidth speed and therefore your video or audio. Use the CVent website chat and Q&A options if you have anything to comment or ask. If you lose connection to this Zoom meeting, please feel free to try connecting again or use the call-in number I will provide on the CVent chat. A special reminder is that there will be a session evaluation available and an overall evaluation for you to complete. We want to provide the best trainings, topics, and experiences that is possible with your feedback. I will make another reminder in the chat and again at the end of the session. I will now start introducing today's speaker. Dr. Sydney Martinez is a Cherokee Nation citizen and an assistant professor in epidemiology in the Department of Biostatistics and Epidemiology at the University of Oklahoma Health Sciences Center. She received her PhD and MPH in epidemiology from OUHSC and a Bachelor's of Science from OU in Health and Exercise Science. She currently studies the intersection of commercial tobacco and diabetes and works towards improving the implementation and delivery of smoking cessation interventions for patients with diabetes in primary care and in tribal healthcare settings. Dr. Martinez also aims to recruit and train the next generations of scientists engaged in health equity research. She is the co-director of the OU Health Stevenson Cancer Center Cancer Research Emerson Summer Program in partnership with Cherokee Nation and Oklahoma State University to provide mentored research experiences for undergraduates and medical students. She also serves as the Director of Indigenous Research at the Society for Research on Nicotine and Tobacco University, curating online content related to international indigenous commercial tobacco research. Thank you, Dr. Martinez, for being a part of this event, and I will now turn it over to you.
All right, thank you, Charmaine. Can you see my slides? Just the slideshow part? Okay, perfect. Thank you very much. And welcome everyone to today's session. Thanks for being here. I am excited to go over Epidemiology 101 with everyone. I really like introducing this topic. I actually got my first introduction of epidemiology at the Southern Plains Tribal Health Board. I was an undergraduate student en route to maybe physical therapy or med school. I wasn't sure what I wanted to do, and I was interested in tribal health organizations, and I found the Southern Plains Tribal Health Board and the Tribal Epicenter. And I actually went in to look at volunteer opportunities and had to Google epidemiology because I did not know even what that was. And then I just kind of fell in love with this topic and made it my career. So happy to share this with you all today. Advance the slides. Okay, so the learning objectives for today's talk are to define epidemiology and describe 3 uses of epidemiology. You should be able to define the terms descriptive and analytic epidemiology, and then also just walk away able to discuss ways in which an epidemiologist thinks critically to identify ways of improving public health. So I like to, teach people how to think like an epidemiologist. So in order to do this, we first need to know, what is an epidemiologist? Before the pandemic, before 2022 or 2020, a lot of people would ask, is this a skin doctor? So they would think epidermis for epidemiology, and this is not correct. That's more dermatology. So it's not epidermis. Then people might move into epidemic. So they would decide, remember the hot zone or, these big outbreak investigations and think of the CDC. So they're getting closer. But now after COVID-19 and everyone has heard, epidemiologists on the news, a lot more people are familiar with public health in general. So you may have heard this, term quite a bit more now. But let's go into let's break down the word epidemiology and then think about more of a detailed definition. So the actual word epidemiology is the study upon people. So ology is study of, and then, really upon people, but that's still a little bit unclear of, how do you study people and in what context. So the long definition, which I'll break down, is the study of the distribution and determinants of health-related states and events in populations, and then also the application of this study to control health problems. So this is a definition by John Last in the Dictionary of Epidemiology. So again, that's a mouthful and a lot of moving pieces. I'll break this down a little bit more. So epidemiology is the study of, this is referring to measurement of disease frequency involving quantification. So, actually quantifying numbers and getting data of the existence or occurrence of disease. So in epidemiology, we have surveillance, where we're always tracking and monitoring disease trends over time and in different locations. We have observation, so we could do observational studies where we are observing different exposures and then outcomes to see if a certain exposure is associated with or causing a certain disease or health outcome. We have hypothesis testing for this type of study. So we want to generate hypotheses and then test those to see if they're true or not. So we might have hypotheses around differences if something is significantly different, or if we have a cause and effect that we're looking at, or we have an intervention. So we want to test an intervention to see if that improves the health outcome. So we can use hypothesis testing for that. We have descriptive research, which is where, we'll talk about descriptive and analytic epi in a little bit, but, where you're describing the health status of a population, and then analytic research where you're testing those hypotheses. And then experimental research, like I said, with interventions or public health programs that you might be implementing. You might implement one in one community and compare that to a community that does not have it implemented. Randomized controlled trials, even to that extent, where you're looking at, therapeutic interventions, that type of thing. So there's lots of ways to study, where a lot of different methods and really rigorous methods in studying these, studying upon people, right? So epidemiology is the study of the distribution. So what do we mean by distribution across populations? So this is the frequency of disease by person, place, and time. So we look for variations from this uniform distribution. So if disease was the same across all types of people, all places and time, then there wouldn't be these patterns. It would just be that's the status of disease. But we want to know, does disease cluster? Are there certain areas where a disease burden is heavier or higher than another area? Are there certain population subgroups that are bearing this heavier burden and disease? And if that's true, then why? What are the causes? Why are certain areas, why is disease clustering in that way? Is that maybe related to an exposure that's more also clustered in that particular subgroup? That's where we start to ask these questions. When we look at the distribution and look at these differences across the population, we start to ask those questions about why and then what can we do about it. So I wanted to give you all a chance to put some thought into what maybe is an example of a type of distribution. So I kind of mentioned person, place, or time. So what so use the chat or unmute your mic to just kind of give me an example of maybe what we would look at a distribution by what type of characteristic. Does anyone have any thoughts?
Dr. Martinez.
Uh-huh.
This is
Hi,
Dana. Hey, how's it going?
Good.
It looks like the chat is disabled.
I think, can you use it in the CVent? Or you can just unmute if you have an example. Anyone think of?
You should be able to use the Zoom chat now if you would like to use that one.
Anyone think of a type of distribution? What would we look at differences across the population by? What kind of characteristics would we look at differences in disease?
How it affects different ages or different groups of individuals.
Yes, so I see race in the chat, and then you mentioned by age, gender. Yes. Anyone else have an example? I think age distribution and race is kind of the most commonly thought of. So I'll go ahead and another one is geographic distribution. So if we're looking at it by location, by type of disease, yes, we could look at, especially if you're thinking of a certain like subtypes of, so if we think of cancer and the different types of cancer, or comparing diseases in a population, yes, those are great examples. So this is a map of COVID-19. That's kind of a little bit older, but COVID-19 case rate per 100,000. And so this is showing the distribution of COVID-19 by state. And so you can see when we look at this, we look at patterns, and we might start to think, if we don't know this at all and we have no idea where COVID is or any other type of disease, then we don't know, kind of these questions of who's getting a particular disease, how is it spreading, that type of thing. And so when we start to map it out, even just counting cases and calculating rates per population size, we can start to look to see, maybe the south, the southern belt is experiencing higher rates of COVID. And so then we can start to ask why is that? What are the factors associated with those higher rates? So this is what we mean by distribution, where it's just kind of those differences across. I see there's a hand raised. Do you have a question?
Sorry. Yeah, I had a question real quick. When you talk about distribution, can it be by any population that you've categorized as a certain population?
Yes.
So not geography, not just race, not just, it could be all kinds of different factors or, okay.
Yes, it's how it's distributed by, kind of differently across, any kind of characteristic you want to think about. These are just kind of the more common ones we look at. Yes, good question. Okay, so moving on through our definition. So epidemiology is the study of the distribution and determinants of health-related states. So what do we mean by determinants? So determinants are any factor or event that brings about a change in a health condition. So this could be these could be physical determinants or physical factors, biological, social, cultural, and behavioral factors that influence health. So these factors, you could think of safe water, clean air. So those could be the physical environment, the differences that might be causing change, change or differences in these health outcomes or health status. It could be different cultural beliefs or support. So it could be the lack of social support or having, strong social support. So those would all be examples of social environment, that those social determinants of health. You might have heard of that kind of statement. We could be talking about socioeconomic status, access to care, or again, lack of access to care. And so those would be economic environment or economic factors. And then we have what we typically think of determinants, maybe not rightfully so. Maybe these other determinants might be even more, are even more, more of a factor, but individual characteristics. So diet, exercise, whether a person, smokes commercial cigarettes or not, those types of individual characteristics that may or may not put someone at risk for a certain disease or health outcome. And then biology and genetics. So all of these factors are considered determinants. And really with epi, the field is so broad, you can really think of you can think outside the box and think of a lot of different types of factors that are really potentially determinants of health. Yeah. So again, epidemiology is the study of the distribution of determinants of health-related states and events. And so when we say health-related states, we don't just say disease. A lot of times we'll default to disease because in epi we are looking at diseases often, but really it could mean anything that's related to health. So this could be our typical infectious disease and chronic disease and death, but it can include injuries, motor vehicle accidents, just the accidents themselves. It could be disabilities, mental health disorders, suicide, substance use, behaviors. So you could be looking at what factors influence exercise as your sort of health-related state that you're interested in. Use of health services. So it could be, accessing screenings, for example, or participating in screenings, and then adverse events. So it could be, weather-related events or tragedies or those types of events. So anything that might impact health really can be studied with epidemiology. We typically will have infectious disease epidemiologists and chronic disease epidemiologists, and we learn methods that are kind of for both of those kind of tracks. We've learned with the COVID pandemic that even if you've trained in chronic diseases primarily, you still can use that outcome. There's some nuances related to transmission of infectious disease that's a little bit different than chronic, but really a lot of people who focus primarily on chronic disease ended up studying the COVID pandemic. And then really, like I said, you could take any outcome. I know the FAA, Federal Aviation Administration, has an epidemiologist position that looks at plane, crashes, and there are oil and gas industry companies that have an epidemiologist that are really studying their morbidity and mortality of their employee populations, occupational health. So really, a lot of different health-related states and events can be studied with epidemiology. So we're looking at the study of the distribution of and determinants of health and events in populations. So populations may be one of the most important pieces of the definition of epidemiology. And this is really looking at disease occurrence among population groups rather than individuals. We count the individuals, but we aggregate those to a total amount, that we're looking at, or a rate in a population. And this is very different than just your traditional clinical medicine. So in clinical practice, you're interested in that one patient that's in front of you to determine whether they have a disease or not, what their prognosis is, what their treatment should be. So you're looking at really those individual one-on-one, a clinician and a patient kind of dynamic. Whereas with epi, we sometimes call this population medicine. So we're still looking at health and health status and disease and outcomes and prognosis, but we're looking at that on a population level. So we're looking at how does this exposure affect, an entire population or a subgroup of a population, rather than those one-on-one. And this is it's a different mindset because you, especially when it comes to like screening for cancer and that sort of thing, because everybody wants to know their individual, if you have a family member or someone that, has a kind of a potential risk for disease, you want to know what is the likelihood that one person has that disease. And so with population, with epi, a lot of times we're looking at, if we start to screen the entire population, what's the cost benefit of that? How, what are the unintended consequences of starting to do something at that, on the population level, that type of thing. So it's definitely kind of a little bit of a mind shift, but they go hand in hand. We, as an epidemiologist, I work with a lot of clinicians in research and in practice. And so we use epidemiology to inform clinical practice a lot of times, where we study it on a population level to see how that's affected. And then we can deliver, we can kind of give that information back to clinicians for best practices. Yeah, so the biggest thing to remember for epi is we're learning about diseases and health status, across populations. So, finally, we're looking at this distribution, but also we're looking at the study to control health problems. So we don't want to just understand where the disease burden is in the population. We want to actually understand how do we control health problems or improve the health outcomes and health status of a population. And so, this is the, specifically the aim of EPI, which is to learn, understand those patterns, but then promote, protect, and restore health. So we want to make improvements. If we notice differences across distribution, so racial differences, for example, if we understand that burden of American Indian populations is a lot higher, then we want to know, how do we actually work towards, achieving health equity rather than just monitoring these trends over time. So it's really about that application and prevention and improvement. So that's a long definition that hopefully breaking it down makes it a little bit easier. But then kind of take away what is epidemiology really? So it's the study of health and disease in populations. That's sort of the small, short elevator pitch that I share with people when people ask. But it's the basic science of public health. So we want to know who gets disease, what causes that disease or diseases, how is disease spread, what prevents disease, and then what works in controlling the disease. So if you think about when COVID-19 first started, it was a new virus. We didn't know what the patterns were going to be like. We had to, we were looking for guidance. Each individual was looking for guidance. What do I do? How do I, decrease my risk of getting COVID and that type of thing. But we really had to use EPI to fully understand the patterns of that virus, understand who gets the disease, who gets severe disease versus mild disease, what causes that disease. So understand for non-infectious disease, it's actually a little easier because you almost always know the virus pretty quickly. But for other chronic diseases, it's usually a multifactorial, cause. And so they, understanding, those types of subtle, risk factors and combination of causes. And then how does it spread? The monkeypox pandemic or epidemic that's in the news a lot right now. These are the questions that we ask a lot of times for those new emerging diseases or newly spreading, these epidemics that happen. Monkeypox isn't new, but it's all of a sudden kind of spreading. So, knowing what causes the disease then carries over into, okay, now how do we prevent disease? If we understand the mechanism of the spread, then we can understand those mitigation strategies a little bit better. And or behavior change. So how do we implement, how do we affect health on a policy level? Or access to care, how do we improve access to care? If, knowing these causes and determinants allows us to start addressing those. And then also using the same type of methods allows us to identify what works. So when we put in an intervention or a public health program, we want to evaluate that. And you can use similar, epidemiology methods to evaluate whether that's working or not. So because sometimes when what you think is going to work, there's still maybe some challenges around that. Yeah, so all of this is encompassed by epidemiology. And then the scope, again, is just to, describe the health status of populations, then also explain the etiology or the cause of disease, predict the occurrence of disease. So a lot, what do we want to know for the COVID pandemic? What's ahead of us? How long is this going to last? How do we predict these surges? How long is the surge going to, last, or how rapidly is this increasing? What's the fall going to look like when flu hits too? All of those types of questions that we were asking as a population and individuals. We use epidemiology to learn from previous diseases and learn from history and use statistical methods to try to predict what's going to happen. It's not always correct, but we, epidemiologists and biostatisticians kind of try their best to understand or to predict the occurrence of disease, and then control the distribution. So we definitely want to continue to improve the health of population. Here's a long list of various epidemiologic research and practice areas. So really you can think of anything associated with health, but here's a list of more specific ones. So cardiovascular disease epi, clinical epi, injury, nutrition, veterinary epidemiology. So a lot of our zoonotic diseases, we have veterinarians that learned animal science. And so then they learn how, the animal to human spread of disease, how that plays together. Molecular and genetic epi. So really, sky's the limit with these kind of specialty areas. And what I love about epi is that we specialize in these areas, but we don't necessarily have to stay in one area. You can learn the methods and then translate that across, really you learn the basics of that exposure outcome, kind of, how to look at those patterns between exposures and outcomes, and you can change the exposure and outcome you still need the content knowledge, and that's why we work together with, experts in those areas. But really you can apply epi to a lot of different areas. Okay, so that's kind of very broad overview. I was trying to, when I was thinking about what to cover for this hour, I realized, that we could have, semester-long courses and programs for epidemiology. So I was trying to kind of think through just some very broad, basic, epi 101 things to cover. So I wanted to go over descriptive versus analytic epi, because they're two kind of separate uses of epi, but they go together as well. And then I just wanted to go through just some key terms. So I've been saying exposure quite a bit. So when we think of an exposure, really that's a broad, another way of kind of saying these determinants. So really it can be anything that might affect health. So exposure, a lot of times in epi, we think of exposure and an outcome. So the disease or outcome can be any of those health-related states that we mentioned too. So not necessarily just a disease. And then morbidity, we're talking about illness of a specific disease. And then mortality, of course, is referring to death from that particular disease. So those are just some terms I may have already used, but or might use. So what is descriptive epi? So this is usually what we do for our first step. So we want to, there are usually these unequal distributions of health and disease in a population. We want to describe those differences. We talked about distributions. So we want to know who was affected, where did this event occur, or health status differences occur, and then when. So looking at time trends. Because if you start to, if you have a typical pattern, then all of a sudden you start to have an increase in an increase in a certain disease, you start to ask your questions. Why are we seeing all of a sudden this uptick in a certain disease or an emerging disease or behavior patterns that are different, that are changing? So we want to always look at these differences and just kind of understand that baseline and be able to monitor that over time. We want to be able to classify disease according to person, place, and time. So we talked about this quite a bit with in terms of distribution. So another kind of piece to distribution is everybody might be more familiar with like a bell curve, where kind of if you're thinking about your grades in a class, and everybody kind of the average grade, and then you have some that have A's and some that are failing. That's just that bell curve. So a lot of our health distributions don't look like bell curves. So if you think of a disease that the risk increases as we age, it would look different. You would have higher distribution or higher frequency in the older age groups. So you can look, we want to know these distributions and patterns of disease. So we want to use descriptive epi to evaluate these trends, and then use this as a basis for planning. So anytime you've implemented maybe a public health program, you want to know that baseline, and then that way you can kind of monitor changes over time and know if your program has had an impact. So before we can do all that, we have to have that just basic description of what the status of health is currently. We want to identify problems to be studied by analytic methods. So we want to use these patterns to then ask questions. We want to see these differences and say, now why do these diseases, or why do these differences exist? Is there a change in exposure of a certain, if we don't know, certain, health related states, we don't know what's really causing, or what's really impacting the multi-factor diseases. There could be multiple things. We have to figure out what is actually increasing if a disease is increasing. So we want to study understand the situation to then further investigate. So just looking at trends, so this is looking at crude cancer incidence and mortality rates for the American Indian versus non-Hispanic white population in Oklahoma. So we can see by age, cancer increases, but there's a higher both incidence and mortality for American Indians compared to whites in Oklahoma. So this is from the Stevenson Cancer Center data briefs. If you're interested in more data, you can go to that website. So this is basic descriptive epi. So where we're just, we're not saying why this has happened. We're just saying these are the trends. These are the patterns that we see. So this is, provides valuable information for prevention of disease, designing interventions, and really this is the first step for us to then ask our next questions as to kind of like why is this happening. Another example of descriptive epi are the community health profiles that you might be aware of from either, tribes might have these community health profiles, or here's the TEC's profile. And so any of these comprehensive needs assessments or that kind of thing, that's where you're really describing the current status of a population. And then you might see those differences. You might be able to come up with health priorities based on, which one is, which of the ones are most burdensome or where the biggest, largest disparities, that kind of thing. So that's descriptive epi. And then we typically start there and then move into analytic epidemiology. So this is where we want to further investigate those, potential hypotheses that we have. So we want to kind of describe these differences and come up with a theory or a hypothesis for why those differences might be there. And so then we want to test those associations. So we look for causes and effects of why those differences exist, why disease is maybe is increasing or decreasing, and really start to get an understanding of an exposure and an outcome association, and is it causal? And we wanted to generate conclusions about particular health related states. So this is where we actually want our answer. So the descriptive epi kind of shows us the differences, and then we kind of think why are those differences? Could it be this? Could it be differences in socioeconomic status? Could it be differences in health behaviors? And then analytic epi is where we come in and actually kind of test that out to come up with our conclusions for our what we're investigating. So the importance of analytic studies, this leads to the prevention of disease. Until we understand, we don't have to understand fully. Sometimes you can, if something's good, helpful, we don't need to know everything perfectly, but we definitely need to know, we need to start to generate these hypotheses and start to think of, what could prevent disease. This helps us create quantitative evaluations of interventions. So we can use analytic epi to test and look for statistically significant differences between groups to really make sure that those associations are true. We can look at aiding, determining safety and efficacy of new drugs and other procedures. So lots of different uses for analytic epidemiology. So just thinking about those differences, descriptive epi is hypothesis generating. So we're describing the population and coming up with our questions, why, our thoughts for why differences might be there. And then analytic epi is where we go and test those hypotheses. So we do a lot more, that would be more rigorous, statistical methods to test those differences. And then we can generate, conclusions based on those differences as well. So in our descriptive epi side of the field, we are looking usually at more of the cross-sectional type studies. So all of our behavioral risk factor surveillance surveys, sort of those big surveys where we ask about health status, previous diagnosis, health behaviors, that a lot of that's descriptive epi, a lot of compiling, like I said, the community health needs assessments that are done where you're just compiling all of the existing data that you have on the health status of the population. You can get into some ecological studies and case studies, but yeah, that's typically what we think of for descriptive. Whereas in analytic studies that's where we usually get into your case control studies, maybe your cohort or longitudinal follow-up studies where you get a cohort and you follow them over time. So like the Strong Heart study is a longitudinal study. And then we think about too our intervention studies. So when we're doing either a clinical trial for a new drug or therapeutic intervention, or we can even think about community intervention. So this would be analytic epi, where you have an intervention group or a community group that's getting the intervention, maybe have a control. And so, yeah, these are the kind of two sides to epidemiologic studies that we have. Are there any questions on kind of the descriptive and analytic epi before I move on? Or any comments? Okay, stop me if you have a question. So now I'd like to take a little bit of time to talk about how to think like an epidemiologist. So we learned a little bit about what is epidemiology, the kind of main purposes, so descriptive and analytic epi. But now we'll think about, what is it like to think like an epidemiologist? When I think of epi, I think a lot of critical thinking. So we're really trying to make observations and think critically about those observations and what are the differences. Analysis, so really thinking of how do we analyze this in a way that is going to help us get to the truth or the real answer as best to our knowledge. How do we reevaluate if we're not sure if that analysis was correct? Making inferences, so taking results and then kind of coming up with inferences or drawing conclusions about those results. You have to think critically about communication. How do we communicate this to the population in a way that's clear, not misleading, and how do we, we've seen that with the pandemic with some miscommunication and updating information, and how do we explain that to a population that, that the science is evolving. And then problem solving, how do we identify problems? How do we come up with ways of, strategies for solving those problems, and then testing the solutions. How do we think about those solutions and whether we need to find a new solution, that type of thing. So it's pretty iterative and involves a lot of critical thinking. Epidemiology is a lot of times about ruling out alternative explanations. And so a lot of times we'll have an inference made or a conclusion made, and then we have to think about, what are, this is the finding. Is that finding, do we think that that's accurate? And do we think that that will be consistent? If we measured it multiple times, would that be consistent? Or are there alternative explanations for this finding or this answer? So when we think about an observed association, so if you look at an exposure and an outcome and you decide, you do a research study and you find that those are associated. So we find a statistically significant observation of an exposure and outcome. This exposure causes, or we think is associated with this disease or outcome. Then we have to ask, we've put a critical thinking hat on and say, is this a real observed association or is this not real? And there's quite a few explanations or potential reasons why we could have found a significant or we found an association in our study, but it's really not real. So that could be by chance. So when we do a research study or when we're looking at a sample of people, we could randomly by chance have this observed association in this smaller group that's not really true when we get to that big population level. We're always thinking about population with epi. So that's there could be just by chance we found the observation when it's not really true. It could be due to confounding. So confounding is where you have a third variable that's actually influencing that, or it's actually the factor that's leading to disease, but you think that it's the other one. So I'll talk about that in a minute. And then bias. So this is systematic error. So this is a lot of times it's unintentional. A study design is, by nature of who they've selected. So either the selection bias where they've selected the wrong comparison group, information bias where people are remembering their exposure incorrectly. There's lots of sources of the systematic error that bias our kind of conclusions. And like I said, this can be unintentional by the nature of the study design or other factors. So I wanted to use another, I hate to talk about COVID the whole time, but it's, we can't, it's a good example, I think, of for everybody, because we all lived through all of this. So smoking initially was reported as having a protective effect on COVID-19. So this is commercial tobacco use. And so, there was a couple early studies released that said, that was talking about, are smokers protected from COVID-19? And they found that the prevalence of smokers hospitalized for COVID-19 was actually less than the prevalence of smoking in the general population. So there were fewer smokers ending up in the hospital from COVID-19, and they were, their first initial kind of conclusions, and it hit the news, and their first, first inference or conclusion around smoking, and their risk of COVID or severe COVID-19 was that they were actually protected from COVID-19. So put on your epidemiology hat, and what are your initial questions or concerns about this finding? Because it's not really intuitive what we would think. Anyone have any questions about their findings? Or potential explanations for why they might find this? So the conclusion was the prevalence of smokers hospitalized for COVID-19 was less than the prevalence of smoking in the general population.
I have had COVID twice, and I am a smoker. And some of the people that I know have COVID that are not smokers were in the hospital, deathly ill. So I don't know. I thought maybe smoking might have killed some of the bad cells or something. I don't know, but I didn't get sick either time very bad with it. And I'm a heavy smoker since I was 13. So 43 years.
Okay. Yeah. So looking at the kind of anecdotally, so everybody that's heard of people or has had COVID and that sort of thing, you might start to notice these patterns of, smokers that are having better outcomes or not having severe illness, and then non-smokers who are. So you can start to see these patterns that are, different than what we, might expect. So COVID-19 is a strange virus in that it, it's been, whether it's genetically, whether people are increased risk genetically, that might be an issue, or kind of immune response and that sort of thing. So they're, not all smokers are having severe disease, Dana said there might be other factors that weren't considered. Yeah. So they might not have controlled for those factors, people that are hospitalized, they might not be smokers, but they might have other conditions. I think that's might be what you're referring to.
I was just wondering, could it be possible? I know this is usually, and when you get vaccination, you're trying to boost up your immune system to factors. And could it be possible that people that smoke or do those things have got some kind of response already, and the ones that have never been exposed, are like anything else, being brand new exposed to a new disease? I don't know.
Yeah,
it's a crazy idea, but
these are all questions people started to have, and they started looking at, nicotine receptors and different protective mechanisms between, how is nicotine, increased nicotine exposure protective of severe disease. They were looking at but on a basic science level, they were looking at these kind of conditions. So yeah, all of these are good hypotheses, so you start to ask, why is this? Why are not as many smokers ending up in the hospital? Any other thoughts for what about potential biases or problems with the research design that might have, led to this outcome? So when this first comes out, we have to think, is this real or is this not real? And then if we can sort of, critically think about all the reasons maybe it's not. I hate to think of epidemiologists as kind of skeptical, but you want to come up with you kind of come up with or take a finding, and if I see a news story, I dig in further. I'm like, wait a second, that seems contradicting to what we would normally think. So why is that? How did they do this study? Or what are the how did they base their conclusion? What did they base their conclusion on? That's kind of the things you wanted to.
Oh, that's where I was going exactly. I was going to say, what are they, how are they determining the, level of, smokers, for instance, say they're always in the state of not breathing very well or having issues, wouldn't report it maybe.
Oh, I see what you're saying. The low.
And so those that don't
symptoms,
smoke
yeah.
would be more lapsed to saying this is an issue, go, and be hospitalized for it. I don't know.
They're quicker. I see what you mean. They're quicker to realize there's a difference now. And so, then maybe they have, more likely to get tested quicker, maybe. That's very possible. So lots of different, things to think about. So they actually, after those first couple studies came out, they actually debunked this smoker's paradox because, we call it paradox because it didn't seem, you'd think those with, who are smokers at higher risk for other lung type of conditions, that they would be affected by COVID-19 as well, since it goes after the lungs. And so they did find that the smokers, what it was really, counter or contradicting was that it was protective. So it was like helping. And so they found that smokers were not really protected from COVID. So some of the problems with these initial studies that got released, we had pre-publication release. So these papers did not go through peer review. So a lot of times these, the peer-reviewed publications go through several iterations with peers where they're, making sure the methods are sound and improving, the paper and making sure they're not overly stating their conclusions and that sort of thing. There was a chat when we contact Trace, we had the question, are you a current smoker in our survey? Okay. Yes. So asking COVID or smoking status is definitely important. So these papers don't go necessarily through peer review. They were put online fast. So the peer review publication process takes a very long time typically. So they started to do this pre-publication release where they at least put them up there while they're being reviewed. And so we had access to all this new stuff, new information. It was good in some ways because it gets the information faster to the public, but then bad in some ways because some of the papers aren't exactly done well. And so, some of these papers that initially found this were retracted. They found financial conflicts of interest. So they were funded maybe by the tobacco industry, or some of the authors had ties to the tobacco industry. There's some issues with small sample sizes. A lot of times, if you see a finding, you need to look at the sample size and decide whether you think they had enough people to represent. Because if you're taking, you're asking individuals or studying individuals, and if you don't have enough, then you can't say these 10 people represent the entire, all of America or another country. So, that there's issues with these small sample sizes sometimes. And then in these studies specifically, they had a biased comparison group. So what they were doing is they were asking of the people in the hospital for COVID-19, how many smoke? And really what they should have done is compare that to non-smokers. So how likely are smokers to be hospitalized, compared to non-smokers? And so this, could potentially have a little bit of survival bias. So those who were, that there might be differences in those who are in the hospital versus there could be age differences. Those who survive long enough to be hospitalized were maybe less likely to be smokers. Lots of different factors that they weren't taking into consideration, for these earlier studies. And once they kind of flipped that comparison group and started looking at, then they decided that smoking was not necessarily protective anymore of COVID-19. So this is just kind of a quick example to go through and think critically about each step of the way, what could have gone wrong in each step of the way. And then what you want to do, obviously, is kind of design studies that you're going to minimize, this potential for bias up front. But definitely for you to put on your epidemiology hat, and think like an epidemiologist. You want to be reading the literature and or news articles and thinking about all of these things as you're coming up with your own conclusions. So bias, again, is just a systematic departure from the truth. So this could be in the design, conduct, or analysis of a study that results in kind of a mistaken estimate of an exposure and a disease outcome. And then confounding would be, I mentioned this before. So this is an influence of an exposure mixed with effect of another. So it's when we're looking at a risk factor and an outcome, and really there's a third variable that's causing that associate, or that's distorting the association, making it look like it's that exposure, but really it's this other variable. So for an example of this, if we were looking at say we don't have any idea why lung cancer, what causes lung cancer, we have no idea. And maybe we want to look at drinking alcohol. So drinking alcohol and the association with lung cancer, we might find an association, but what really is happening here is that those who drink alcohol are more likely to smoke, and then smoking is actually the cause of lung cancer. So smoking is confounding the relationship between drinking alcohol and lung cancer. So just in conclusion, EPI is, again, the study of the distribution and determinants of health-related states and events across populations. Populations is important. And then the application of that study to control health problems. And then we talked about two different sides of EPI. So descriptive, where we're classifying disease by person, place, or time. And then analytic EPI, where we're looking for those causes and effects and asking the questions why and how are these differences occurring. And then remember to think like an epidemiologist. So you want to ask questions and think critically, look for alternative explanations, and gather all the evidence, which evolves over time as we start to learn more and more, and we start to we start to try to confirm those studies by doing additional studies. You want to see those patterns across more than one study and across populations if we're trying to think about, get to the bottom of, is this, determinant related to this disease or health-related state. And that's all I have for you today. If you have any questions, please let me know. Are there any questions? Or you can, unmute your mic and ask, or type it in the chat as well.
I just have a comment on the COVID.
Mm-hmm.
I got both the vaccines. And before I had the first booster, I got COVID twice. So then I got the booster. And then 6 months later, I talked the pharmacy into giving me another booster. Well, my son's family all had COVID like 3 weeks ago. And I ate after my grandsons, and we sucked on suckers and ate popsicles. And I never did get the COVID. So I'm thinking that second booster shot worked for me. So
yeah.
What's the CDC saying about booster shots? I mean, is there too many, or are we going to be able to get one every year, or what's happening with that?
Yeah, I'm not sure kind of the current status. I know that they're trying to update the booster for the new variants that are coming out. And so I'm not sure the timing of when they're going to, expect that. I know that, it's becoming clear that it's not going to go away, and that it might be kind of in line with the flu, that we do need the kind of updated ones each year. We don't know the timing of whether that be once a year or more often. I think that's what, they're really having to use those prediction models and try to figure out the best approach. My son was the same way. He had a booster shot, and then everybody else got it, and he was protected. And so I do think that, the boosters increase that immune response, for at least temporarily. We're not sure the duration that helps, and that's why we're asked to get boosters. But yeah, we'll just have to kind of keep up to date with what they're telling us. Yeah, but that's great. Hopefully everybody is well in your family still. COVID's been really, I think it's brought it to the forefront of everyone, with news and everybody. It kind of, we learned about this in public health. Before the pandemic, we learned about all of this, possibility with the 1918 flu as a big example that we learned about, in our programs. But to go through and see it kind of play out live with everyone, having to update their information, and the messaging that has changed over and over and over again, as you can see that as we do more studies and we find out more information and we think critically about what we've seen in the, already, and start to not poke holes, but just kind of question, is this really true? We're able to update our current, what the current state of knowledge changes over time. And COVID's been really different. I think, it behaves very differently than what we have had in the past. So that has caused problems with prediction models, right? So you base it off what you know from the flu and other viruses, and then when it just behaves differently, it's hard to it's like a moving target. Yes? See, Erwin?
And that's exactly what I was going to say. COVID hit so hard, so fast, and public's need for knowledge and predictability and, the vaccine and everything that was going on, that people were putting, obviously, like you said, they didn't have times to do validity and, reliabilities and things like that on their studies, that they just needed to get information out. And like you said, over time, people realized, okay, slow down. We need to think about how we did that, and just like it evolved, like you said, this example you gave. But COVID, I think all the rules went out the window when COVID came, and now that it's here, because we haven't had this in our lifetime, my lifetime, I'm 55. We haven't had this type of, epidemic. So.
Yes. And it was a very new dynamic with social media and all, like, it got very political. It probably did in the 1918 flu too, but yeah, it just got really political, and that didn't help much. But you can, I think COVID, I use it as an example a lot of times because we do remember that feeling of not knowing what it's going to be like, where a lot of other examples, like, we know what causes heart disease, we know a lot of things that cause heart disease, lung cancer, those types of things, but you have to think about when we didn't know, and kind of how do we kind of investigate and find a cause that we don't know about. And that's, or don't know the way it behaves. And so that's, what epi methods are based on and what they can help us with. Any other questions? You probably need a couple minutes to get to your next session, or take a little break. So thank you very much for your participation, and enjoy the rest of your conference.
All right. Thank you again, Dr. Martinez. I definitely enjoyed the presentation. Just a reminder again to please fill out the evaluation for this session and for any other sessions you attend with this training summit. You should be able to see the evaluation card on the event homepage, but we will also be sending out an email to everyone as a reminder on the last day of the event. Thank you all for attending, and I hope you all enjoy the rest of your day.